introduce John Winkelman, who's a professor of psychiatry at Harvard Medical School and director of our department's sleep research program. John's going to be talking about disordered sleep, myths, facts, and remedies. I guess I need to throw out, I think it was sometime in, I don't know, when was it, John, that you were actually my chief resident, right? Yeah. So you want to come up and give your talk?
I thought you were going to say more nice things.
The nicest thing I can say about John, and that impresses me the most, he's married to Janet Wozniak.
That's true. Well, I want to thank the council for organizing this today. I do want to thank Jerry I was his chief resident 26 years ago, for meeting with me weekly and teaching me about psychiatry at that time, and then for welcoming me back to Mass General after I had strayed into the wilderness of Brigham and Women's Hospital for 16 years, and I've been back now for 5. So thank you, Jerry. Can I use this? Yes, I'm going to use this because I just learned that any kind of movement is good for your health. And I'm going to increase my mortality, and I apologize to the cameraman back there. So we're going to talk about sleep today. I have 18 minutes to talk about 1/3 of life. So we'll try to move quickly through this, and I've organized this actually at Jerry's suggestion by myths and facts. And so the first myth that I'll try to dispel, or at least discuss, is that we need less sleep as we age. In fact, we don't really know whether we need less sleep as we age, which is unfortunate that I can't say whether it's a myth or it's a fact. We do know that as people get older, it becomes harder and harder and harder to get a full night's uninterrupted sleep. Anyone in the audience who's experienced that, particularly in the last third of the night. That's the time when people are most vulnerable to sleep disruption associated with aging. So that's a particularly vulnerable time. So moving on, this is really a common myth, is that good sleep means not waking up at all. That's not true. It's not true at all. Sleep is a dynamic state on a second-to-second, minute-to-minute, hour-to-hour basis. It changes. It's not just the absence of wake. Sleep is a very active state. And so we can expect to wake up frequently. We may not be aware of these awakenings. This is a little bit of a polysomnogram. I get to read sleep studies, which I enjoyed tremendously. I read about 1,000 of these a year. That's 25,000 sleep studies I've read during my career. And this little bit in here is actually an arousal from sleep. And we have 10 of those an hour. That's normal to have 10 awakenings from sleep per hour. They may only last 10 seconds or so, but sleep changes frequently during the night, so that's something to expect. Third myth is that one night or a night or two of sleep deprivation is not a problem. Now, I don't want to raise too many alarms. It's not going to be a persistent, long-term. I don't want to get into the bummer that Jeff was talking about. A night or two of sleep is not terrible, but we can see the effects of these, and we'll look at a few examples of that in these next slide. So here's some brain imaging studies, and this little part here is the amygdala, and you can see here one night of partial sleep deprivation leads to substantial increases in activity in the amygdala when you see disturbing pictures. So here's somebody who's fully slept looking at a disturbing picture. The amygdala gets a little bit excited. We're a little bit disturbed by it. On the other hand, getting my exercise and reducing my mortality, you can see that over here with the one night of sleep deprivation, how much more the amygdala, this part of the brain that's involved in emotional reactivity, responds to those same disturbing pictures after one night of partial sleep deprivation. And we all know this. something that somebody does that might be a little bit annoying to us after a night of sleep deprivation becomes that much more annoying. And this is a reflection of that in terms of the brain. So we're more emotionally reactive after sleep deprivation. Second, learning is impaired with sleep deprivation. So here's somebody, this axis here is how many addition and subtraction problems you can do in a certain amount of time. And you can see that with 8 hours of sleep, we get better day to day to day to day. This is over 2 weeks. We get better and better and better and better with 8 hours of sleep. With 6 hours of sleep, you can see our learning is substantially impaired. We're really not doing much better at all. With 4 hours of sleep, there is no learning at all. No improvement in performance over this 2 weeks until we're given recovery sleep, and then all of a sudden we get better at this problem. So for those young kids in school, try to get your sleep. That's the best way to learn. And I think the final example here is that sleep seems to be important in removing toxic metabolites from the brain. We've just discovered a lymphatic system in the brain called the glymphatic system, which here is in this beautiful orange-yellow. This is a slide from Nora Volkow at National Institute of Drug Abuse. And when people are sleep deprived, there is an increase in some of these toxic products, in this case beta amyloid, which is seen in high concentrations in individuals with neurodegenerative disorders like Alzheimer's disease, so that with sleep deprivation, the glymphatic system seems to close down, and so these metabolites are not cleaned from the brain as efficiently, and they therefore build up in the brain. And final little bit of data, one not cute, it's not really cute, I'll call it an elegant study that was done at the University of Chicago a number of years ago, took undergraduates and they gave them 4 hours of sleep 6 nights in a row, and they gave them intravenous glucose and looked at what their blood sugar looked like over the next few hours. Those individuals who had had that partial sleep deprivation, 4 hours of sleep for 6 nights in a row, looked as if they were becoming diabetic, just in terms of the glucose curve. So this extended significant sleep deprivation is associated with significant changes in the metabolism of sugars. Myth number 4, chronic sleep disturbance is not a problem. And in this case, I would say chronic sleep disturbance is a problem. Acute, 1 or 2 nights bad sleep, not a big issue. Chronic sleep disturbance, we're more concerned about. And I think Jeff Hoffman described some of this already, this bi-directional relationship between psychiatric illness and sleep disorders. Yes, we know that depression causes sleep disorders, but over the last 20 years, we now recognize that these sleep disorders also can cause psychiatric illness. And this is true for a variety of medical illnesses as well, as he was describing in terms of cardiovascular disease. Specifically, we're talking about these sleep disorders that I've studied for the last 25 years and done research in these different areas. Insomnia, everybody knows what that is. Hypersomnia, these are people that sleep too much or are excessively sleepy during the day. Anybody who might be falling asleep here during this fascinating talk, I would consider might be at risk of that. Restless leg syndrome, an area where I've done a lot of my research, which is a neurological disorder affecting this feeling that you have to move your legs, particularly at night, making sleep impossible. And then, of course, obstructive sleep apnea, which is obstruction in the upper airway during sleep, the smallest symptom of which is snoring. So this bidirectional relationship, psychiatric illness, medical illnesses, and sleep disorders. And round we go. Chronic sleep loss is also a risk factor for suicide. A number of studies showing this, that even controlling for the degree of depression, that sleep disturbance is a risk for completed suicides. And finally, on sleep, chronic sleep deprivation is this U-shaped curve between the amount of sleep you get from 3 hours here to 11 hours and your risk of a variety of bad things: mortality, cardiovascular disease, coronary heart disease, stroke. 6 to 7 hours, 6 to 8 hours, particularly right around 7 hours is the sweet spot. Any more than 9, any less than 6 increases your risk. And so this leaves us in the situation with all of these things that it is chicken and egg. We can't say who goes first, and this is this bidirectional relationship. Myth 5, insomniacs accurately estimate their time awake at night. Not true. Here's what we call a hypnogram. The sleep stages of somebody looks absolutely normal. Going into deep sleep, REM sleep, just teeny little awakenings. This is a patient who said to me the next morning, "I didn't sleep at all in the sleep laboratory." Who's right? Are we right or are they right? We're both right. Sleep is both an objective experience we can record in the sleep laboratory and a subjective experience. So we can't really say that he did sleep. If he says he didn't sleep, he didn't sleep. But in the sleep laboratory, obviously, we're recorded differently, and this is one of the interesting facets of sleep medicine. Our next, and I think next to last myth, is medications are the only effective treatment for insomnia. This is not true. Cognitive behavioral therapy for insomnia, as I was talking to a few people about last night, is first-line therapy for insomnia, for chronic insomnia. Just as effective, maybe even more effective than medications. American College of Physicians recommends this as first-line therapy. Almost every guideline you read is going to recommend this as first-line therapy. It's a multi-component treatment involving sleep restriction, stimulus control, cognitive therapies, relaxation therapy, sleep hygiene. The key is probably restriction of time in bed. People with insomnia spend more and more time in bed trying to squeeze out the last little bit of sleep. Probably a compensation that is not a good idea. Rather, better to spend less time in bed deepening sleep rather than making it very thin. All these other therapies are valuable as well. CBT is not only available in person-to-person therapy, but online as well. Unfortunately, there are not enough CBT therapists. Even in the great city of Boston, we have 3 or 4 people that do CBT for insomnia. That's it. And chronic insomnia is 10 to 12% of the adult population. We're far understaffed. But these online therapies can be quite valuable and have been shown to be effective. I think this may be the last myth. Medication treatments for insomnia are dangerous. Well, maybe some are not such a good idea. This is an actual ad from a medical journal from the 1960s that I pulled out and copied. Some medicines are not so some sleep medicines are not such a good idea, particularly the barbiturates. We've got lots of good medications now. Some of those medicines, though, can produce problems. It is true. But some people exaggerate them. Some others of us try to lead to a balanced perspective on the efficacy, and this is a very popular topic. Here you see a much younger version of John Winkelman talking to Oprah here about just this issue. As you can imagine, she was very interested in this and the effects on appetite, but you have to realize that there's a balanced perspective, and when you see things in the media about sleeping medications, make sure that you take them with a grain of salt. So 4 sleeping pills. The do's: take the lowest dose possible for the shortest period of time in bed. Don't take them and then decide you're going to go to 7-Eleven and get a Slurpee. Or it's a good time to talk to your children or your parents or your siblings about what's on your mind. Not good. Don't mix sleeping medicines with alcohol or pain medicines. And importantly, if you take a sleeping medication, make sure you have the room and the way to the bathroom well lit, because sleeping medicines can impair coordination, and so you really want to make sure you don't fall. Some don'ts. Sleeping pills do not produce dementia. Sleeping pills do not increase mortality risks. The studies that show these are extraordinarily confounded. But at the same time, sleeping pills don't cure insomnia. If you have chronic insomnia, it's really a good idea to talk to your doctor. My final slide, John. So how to get the best sleep? Try to get 6 to 8 hours. If you're my age and kind of advanced, getting older, you're not going to get 8 probably. You're certainly not going to get 10. That's a fantasy. Don't try to get that much, because you'll spend more and more time in bed awake, more and more time upset about the fact that you're not sleeping. 6 to 8, very reasonable. Only try to sleep if you're sleepy. It doesn't make sense to try to lie down if you're not sleepy. And I would use the analogy to sitting on the toilet. You don't look at your watch and say, well, it's a good time to sit down now. Maybe something will happen, I don't know. From a young age, we learn to listen to our bodies, correct? Listen to your body. If it's not sleepy, don't lie down and try. Third, if you're not sleeping during the night and you're really not sleepy, stop trying for a little while. R&D, relaxation and distraction. Take your mind off of the things where your mind goes at night, which is usually not good places. We're not good at reality testing in the middle of the night. Our thoughts go to negative places. Stop that. R&D is good. And if any of these are present, you should probably consult with a physician. Loud snoring, leg kicking, acting out dreams, excessive daytime sleepiness suggest evaluation by somebody, your primary care doctor, or maybe even a sleep medicine doctor such as myself. Thank you very much.
We have time for a question or two, but first, I'm just still feeling bad about his feeling that I didn't say enough nice things, and so since I'm pretty nimble in rationalization, I thought back to something that Red Auerbach said to us once in a case conference. We brought him in, and he said, the secret to being a great coach is knowing who to kick and who to kiss. So I'll leave it at that. A couple of questions for John. Yes.
A lot of my friends take Ambien, and I'm very much against it, but I'm wondering if I'm right. They've had bad experiences. Some have fallen downstairs and broken bones, others have been in cars and driven places.
Yeah. These medicines, as I showed there, can be associated. Okay, the question is Ambien safe, and is it a good idea? And here's someone who says that she has friends who's using it, but she's against it. I'm not sure it's really something you can be for or against. It's a medical issue, and an evaluation by the physician makes sense. It does have, these medicines do have risks, and they have benefits. And the physician needs to balance those, and it's, people do fall down after taking the medicine, do go and eat in the middle of the night and driving. All of those are bad. But we have to weigh against that the known side effects, if you will, of sleeplessness. And so for each person, you make this decision about whether you think the risk-benefit ratio, this balance, is in which favor. And that really is an individual-by-individual situation. Chronic use of sleeping medications. If you've got a chronic sleep problem, you need a chronic sleep treatment. Cognitive behavioral therapy for insomnia is the first-line therapy. However, for people with chronic sleep problems, we need a chronic solution that's going to work. So I'm not against sleeping medications chronically, just like I'm not against SSRIs chronically for people with depression. Oh, a year, the depression's gone, you shouldn't take that medicine anymore. We need chronic solutions, but evaluation by your doctor is probably the best approach.
Older people seem to want to nap later in the afternoon. Does that disturb?
Younger people too.
Oh, does that disturb that required number of sleep hours usually?
So the question's about napping, good or bad. If you have insomnia at night, napping is probably going to interfere with sleep drive that night. You build up sleep drive during the day, and you discharge it at night. So it's like a glass that you're filling up with water, and at night it overflows, and then you go to sleep. And so what you're doing with that nap is as the glass is filling up, you're pouring some of it out. So there's going to be less there at night, less sleep drive. If you're somebody with insomnia, I generally recommend to avoid napping during the day, unless you don't mind having some sleep at night, maybe some wake at night, then some sleep after that, and then sleep during a little bit of sleep during the day. If that doesn't bother you, and I would say that that's completely fine, then it's okay to have this kind of 2 periods of sleep at night with a little awakening, an hour or 2 awakening in the middle of the night. It's a great time to watch a movie, and then a nap during the day. I think that's okay, and that's probably how we slept 100 or 200 years ago. There was something, if you read the history books, first sleep and second sleep, and everybody in the family was up for an hour or 2 in the middle of the night. So this consolidated period of sleep at night is maybe a relatively new phenomenon and is hard for some people. So napping would be okay as long as you're willing to accept that.
But when we show the sleep deprivation with the scans, if someone is getting maybe 4 hours sleep a night, an hour or 2, broken
Right.
on the day, is that considered
That's probably in 4 hours a night and an hour or 2 during the day is probably not enough. And I would look for such a young person like yourself, I might look to see if I could identify the sources of sleep disturbance at night. Because something may be waking you up, even though you still have sleep drive there, something's waking you up.
John, yeah,
Ready? Want to do one more?
or Donna? Yeah.
So if you're someone who's in bed 6 to 8 hours a night, you haven't had a sleep study, you know you have interrupted sleep, how do you know if you're, as an individual, without seeing a physician, how do you know if you're getting enough sleep? How do you know, is it because you feel tired?
Right. Well, this gets to the fundamental question that I cannot answer. And that is kind of humiliating to be spending 25 years and before that 5 years doing a PhD in sleep physiology. What is the function of sleep? How do we judge if we're getting enough or not? And we don't have the answer to that. I would say that basically, if you're having trouble staying awake during the day, in sedentary conditions, where you're not stimulated, I would say then clearly you're not getting enough sleep or there's a problem with the quality of your sleep. If you feel fatigued, that may be sleep-related, may not be sleep-related. So it's hard to self-diagnose in this context, but certainly those 2 symptoms would be an indication that sleep is not doing what it should be doing.
Thank you, John.
You're welcome.
So our next speaker is